Okay, good morning. Good morning, everyone. We'll be finishing up our last topic in the area of neuropharmacology today with anesthetics. And then I think next week you're going to start on a section of antimicrobials, antibiotic drugs. So something very different in terms of topic after today. So what I'm going to finish with is some background overview information for the use of anesthetics. You're going to, of course, learn more about the practical aspects of using these drugs next year and the following year when you're using these agents. But we're going to go through some of the background mechanisms of action and some of the terminology, again, as always, associated with the particular application and use of these agents as anesthetics to promote and facilitate surgical procedures and also to provide analgesia in many cases for the relief of pain during the procedure. So we'll go ahead and get into this a little bit. So in terms of background, as far as just understanding what we're trying to accomplish, we've already looked at a circuit diagram when we talked about analgesics and opioids in particular and other agents. And the basic idea is that we've got some sensory input typically that's carried into the spinal column from DRG, dorsal root ganglion neurons that are sensing what's going on out in the periphery. And this information's coming into the dorsal horn of the spinal column and typically crossing over and ascending up to the higher supraspinal levels of processing where this information is then routed out to the brain where decisions can be made according to what kind of information is coming in. So if we're talking about anesthesia and related aspects of analgesia, pain management that we'll get into a little bit, then there's a number of places along the way here where you potentially can just interrupt the flow of information and affect either consciousness and or the perception of noxious stimuli that provides pain relief if that's interrupted. So essentially anesthesia then just results when the transmission of this sensory information is interrupted somewhere, and so that provides, in most cases, the goal is to provide relief from what otherwise would be very uncomfortable and painful, noxious type of perception of what's going on. So this means that we can then, as I said already, interrupt things at different levels, locally, close to the site of tissue injury or the initiation of a surgical incision, for example, or you can increasingly move up the circuit and get more and more generalized, either regional effects at the spinal level typically, or the whole body, whole animal effects at supraspinal levels. And so you can have a graded, in terms of how much of the body you're affecting with these anesthetics, you can have kind of a graded progression of how much you're intervening and disrupting this sensory information. And there's also, didn't put it in the slide, but there's also descending pathways that can be modulated as well, information that's coming back down from cortical regions and going through areas like the PAG, the periaqueductal gray, that are important as well. But this illustrates the idea that I'm trying to get across, that depending on where you interrupt the progression of the sensory information, that's going to dictate the regional area that you're providing relief for. So in the case of local anesthetics then, these agents that interrupt and prevent the transmission of this sensory information locally are typically, they're referred to as nerve block agents, and they act at the site of administration. So if you block action potential propagation from those DRG cells that are carrying that sensory information into the spinal column, then you're going to interrupt that perception and you'll provide some analgesia at that point, which is the lack of response to that painful stimuli that's been interrupted. So the mechanism of action for the most common drugs that we use in this manner as local anesthetics, the so-called cane drugs, lidocaine is one of the most common that's used, but any of the related drugs, bupivacaine, tetracaine, lidocaine, or novocaine, all of those drugs have a similar mechanism of action in terms of their effects on voltage-gated sodium channels and blocking action potential propagation down the axon of the DRG cells is the mechanism then for how these local anesthetics work to interrupt the transmission of that painful stimuli and provide an anesthetic-like effect in that manner. So one of the things that's a little bit different about local anesthetics is, as opposed to just some other basic types of sodium channel blockers, is it seems that local anesthetics like lidocaine prefer to interact with the voltage-gated sodium channel when it's in an open conformation. So this kind of subtly changes, but in a very important way, it subtly changes the nature of the blockade of the sodium channels by these local anesthetics. And most of you have probably all received local anesthetics for one procedure or another at this point in your life. And so for example, if you're injected with a local anesthetic somewhere in your periphery and one of your extremities or something to get some stitches or whatever else is going on, that there's a numbing of the area typically that provides some pain relief, but you often can still move muscle groups, for example, and still have some control of that extremity, whether it's a finger or whatever that's being worked on. So there's a distinction essentially in the sensitivity of some of the axons of the neurons that are out in that area. Not all of them are immediately blocked, and there's also a preferential blockade of channels that happen to be very active and open. So the basic idea is that if you've got a DRG cell that's responsible for sensing a painful, noxious stimuli, then that neuron's going to start firing. A lot of action potentials are going to be occurring in the axon of that particular neuron, which means the sodium channels are going to spend a lot of time, relatively speaking, in the open conformation. And that's when the drug has the best access to its binding site in the voltage-gated sodium channel, and so it effectively blocks that channel. Prior to this activity, though, if you've got some other neurons next door that are doing other things, like maybe just activating skeletal muscle groups, for example, and activating muscle contraction at neuromuscular junctions, those slower rate of firing sodium channels that are in those nearby neurons that are not very active are largely not affected by the local anesthetic, at least until you vigorously start activating that particular neuron. So that means you'll be able to get some transmission of signal and some function essentially at that neuron, even in the presence of the lidocaine, for example, or the local anesthetic. So this use-dependent idea then explains in part why it seems like the neurons that are the most active are also the ones that are the most affected by the local anesthetic, and it turns out that in the case of trying to provide an anesthetic-like response and disrupting the transmission of the painful stimuli, that's a good thing. So the neurons that are firing the most, that are evidently responding to the stimuli, are also the ones that are best blocked by the local anesthetic due to this use-dependent mechanism of action. Okay, so in terms of terminology, again, we've got some related terms that often go together, but they don't exactly always mean the same thing. So anesthesia is essentially a loss of sensation, and this can occur, as we were just talking about, if you use a local anesthetic, of course, then you're not going to be typically causing a loss of consciousness in the individual. So anesthesia can occur either with or without the loss of consciousness, and anesthesia is basically then disrupting the response to the noxious stimuli. So analgesia, the relief from the pain sensation, may or may not go together with that. So that might initially seem to be a bit at odds with what's going on, but we'll talk a little bit more in a moment about when you might potentially anesthetize a patient but not be providing adequate analgesic relief in terms of the pain perception that's going on in that individual. But just note for now that these two terms aren't literally synonymous. Analgesia and anesthesia are not do not mean exactly the same thing, and we'll talk more about that in a moment. So as far as the classes of anesthetics then, we just mentioned and talked about local anesthetics and drugs like lidocaine and how they work by their use-dependent blockade of voltage-gated sodium channels. And then there are also general anesthetics that are going to be of two basic categories, two basic types. There are injectable agents, and typically these are administered via the IV route. They're often used for the induction of anesthesia. They have properties that we'll talk about that facilitate a smooth, pleasant experience for the most part in terms of inducing anesthesia. And then there are also inhalants or gaseous agents that are most commonly used to maintain a surgical plane or an appropriate depth of anesthesia during a procedure. So there's inhalant that are gaseous agents, and there are injectable agents in terms of categories of general anesthetics that are going to typically cause the loss of consciousness. So as far as what happens during anesthesia, what are the different levels of anesthesia, or planes of anesthesia, or stages of anesthesia as we think about them? So there's a progression as the patient is being treated with these agents, starting off with this initial administration and trying to induce the loss of consciousness with these general anesthetics. And in many cases, there is a so-called kind of transition phase, stage 2, which is a stage where there can be a period of kind of atypical or maybe unexpected excitability of the individual. So we're going to, yes, question.
So if anesthesia doesn't always occur with loss of consciousness, does that mean like local anesthetics and things like that are always considered a stage 1? Because it says like until loss of consciousness.
Right. So from the initial time when you start administering these agents, right? Then that's stage 1. You might be getting some sedation, some euphoria, some anti-anxiety type effects. But then you transition into this period where the individual, the patient, potentially is not fully coherent, but is transitioning to this period of unconsciousness and non-responsiveness. But depending on how you go about, and we're going to talk about how you try to minimize this stage, depending on how you go about getting them to stage 3 eventually, this stage 2 can be a problem essentially in the patient in terms of the state of delirium. There might be some thrashing around or some, as I said, they're not really coherent or responsive in a normal manner, but there could be some reaction essentially to this typically sedative type administration of these drugs that you would expect the individual to just progressively transition through a calming, quieting stage, ultimately to sleep and unconsciousness. There's this sort of unexpected excitability stage that can be manifest, can be evident in the individuals. And so this stage 2, trying to minimize this then is one of the goals of a protocol where you're trying to induce a smooth induction of anesthesia. And so the reason that this happens is likely due to, we talked about a disinhibitory type of mechanism in many circuits of the brain. We'll see that these general anesthetics often work by enhancing GABAergic activity in the brain. And so one of the consequences is, depending on the neural circuitry that's being affected, is that if some inhibitory neurons or circuits are being affected initially and to a greater extent than some excitatory circuits, eventually everything's going to be sedated and depressed and inhibited, but there's this transition period where you might get a little bit of disinhibition and unexpected excitability. And so that's what this stage 2 refers to, sort of like the stage that individuals go through when they ingest alcohol. Even though alcohol is a sedative type drug, a lot of times there's a dose level essentially where you can get an increase in excitability and hyperactivity even though you're administering alcohol, or an opiate drug is another sedative that can exhibit this. So the goal is to try to minimize the stage 2 and rapidly move through that stage of hyperexcitability to try to minimize any problems that might evoke, and get to a plane or a stage of surgical anesthesia where there's not only a loss of consciousness and responsiveness, but there's muscle relaxation and a loss of reflexes then to painful stimuli, to a pinch or a surgical incision, for example, elicits no response in the individual. The respiratory rate begins to decrease, so those autonomic centers in the brainstem and the pons and the medulla that are responsible for maintaining normal respiration begin to be inhibited by these drugs as well. And then ultimately, if you don't manage things appropriately and go too far, then you get into an overdose stage 4 type situation where there's excessive inhibition of the nervous system and you start to shut down these respiratory centers, and so spontaneous respiration then would cease in the individual, and of course that would be potentially a life-threatening situation if there's no other way of supporting the patient at that point. So essentially you're depressing the nervous system to the point where you lose responses to the noxious stimuli that are going to be occurring. And if you go too far, then you can shut down autonomic function in the individual, and that's potentially going to be a life-threatening situation. Question?
So if you were to like administer like IV propofol or something like that, and the patient becomes apneic, would that be in stage 2 or 3 because of the irregular breathing?
I don't know actually how that would be classified and if it matters. I mean, certainly this stage 2 again is essentially a bit of a catch-all for this stage of unpredictability. Like I was saying, what could explain why the individual doesn't just smoothly go down to stage 3? And so different individuals respond differently, and so that could be characterized as something that's happening during that stage, but I'm not certain. Okay, so what we're trying to go for, of course, is to achieve stage 3 and keep them there, not progress to stage 4 and get through stage 2 such that you likely most of the time don't even see that it happens. Okay, so another term before we get into the drugs and how they're used that's relevant for general anesthetics and the gaseous agents in particular is the MAC value of the drugs that we'll be looking at, the minimum alveolar concentration that's required to administer these drugs in a population of individuals, of patients. How much of this substance needs to be administered in order to, on average, achieve surgical anesthesia stage 3 in 50% of the population. So this MAC value is just a number then that can be assigned to the general anesthetic that gives you some indication of its potency. So if it takes a low concentration of the drug to achieve surgical anesthesia in a given patient population, then you would expect that means that particular drug is relatively higher potency than another drug that you're comparing it to. So a low MAC value corresponds to a higher potency in these agents if you're looking at a series of these gaseous agents. So low MAC values then, as we're going to talk about in a few minutes, correlate with high lipid solubility. So we've talked about just a very basic oil-water partition coefficient idea where chemicals, where drugs have physical properties that dictate whether they're going to be either hydrophilic and water-loving or hydrophobic and fat-loving. And so it turns out that low MAC values, high potency agents tend to have a high lipid solubility. They prefer a fattier environment, and so we'll take a look at how that might explain where they work and how they work in terms of their mechanism of action. So for the most part, most of the gaseous agents, one of the things they have in common is they seem to interact with the inhibitory receptors that we've commonly talked about, the GABA A receptors. So they enhance the activity of those inhibitory receptors as you would expect if you're going to be quieting down, shutting down circuits in the nervous system. And so because of this correlation with high lipid solubility, then it's likely that the binding site that these gaseous agents are interacting with on these GABA receptors is probably in a hydrophobic environment, meaning somewhere inside the phospholipid bilayer region of the cell where these receptors are located. So we'll take a look at that in a moment. So this is a diagram that you've seen a number of times now, the GABA A receptor, and we've talked about how GABA A receptors work and where other drugs modulate this receptor. So it's been a very important drug target in terms of explaining mechanism of action of a lot of the drug classes that we've talked about. So in the case of general anesthetics then, it seems that there is a modulatory site in this lipid environment of the inner leaflets of the phospholipid bilayer where this receptor is spanning across the plasma membrane of the cell. So general anesthetics, gaseous agents that we're going to talk about are functioning essentially as modulators of these channels to increase the activity of GABA receptors through their interactions at some binding site in the transmembrane portion of the GABA A receptor. Okay, so we'll come back to looking a little bit more detail with some specific gaseous agents, but as far as the injectable agents go, the ones that we're going to pay attention to, propofol, etomidate, and thiopental, all of these in one way or the other act to enhance the activity of GABA at GABA A receptors. So turning up the activity and effectiveness of GABA A receptors is what's explaining the anesthetic-like effects in terms of the loss of consciousness that the individual, that the patient that's subjected to these agents is going to eventually experience. So, however, it's interesting that if you use them alone, these agents that act at the GABA A receptor complex, they do not provide what's considered to be sufficient analgesia. So this is an example where there's a distinction between an anesthetic effect and an analgesic effect. So how do we know this, or potentially what's the evidence for this idea? So if you get an inhibition of consciousness in the individual such that they're no longer responsive to noxious stimuli, then you've achieved anesthesia. However, if you monitor autonomic reflexes, blood pressure, heart rate, for example, of what's happening in the patient when you start to make a surgical incision, for example, or from the ongoing trauma that the individual has experienced through whatever's happened prior to attempting to treat them, you'll find that their autonomic reflexes, even though they're unconscious, their autonomic signs are telling you that they're still experiencing or sensing some sort of noxious, painful perception in the nervous system. So even though they can't respond, even though they might not be conscious, it's evidence that there's still painful perception occurring at some level of the nervous system. And so that's how we can distinguish at times between analgesia and anesthesia. Even if the individual isn't responding to the noxious stimulus, that doesn't necessarily mean exclusively that there's no perception of pain going on at some level, subconscious level, for example, in the nervous system. So that just means that by themselves, these agents then are not sufficient to maintain an appropriate, you might think of it as a humane or sufficient level of analgesic relief during a surgical procedure. So that needs to be kept in mind. So when are they used? These agents, as I said, are used as induction agents. They tend to have properties that take the patient down fairly quickly, progress rapidly through stage 2, such that it's not even relevant in most cases, and get the individual unconscious, relaxed, and ready for the progression of the anesthetic protocol. Ketamine is another injectable agent that's a little bit different in terms of its mechanism of action. We've talked about NMDA receptors, glutamate receptors before. We mentioned ketamine as an NMDA receptor blocker. It's a PCP-like compound. It shares that mechanism of action of of blocking the pour of the NMDA receptors. And so one of the things that's advantageous about ketamine is that unlike these other injectable agents, it seems to provide reasonably sufficient analgesia relief to the individual. So ketamine is a fairly effective analgesic. It's normally used in combination with other substances, but even on its own, it provides a fair amount of analgesia. And because of this different mechanism of action, it doesn't have quite as severe effects on cardiovascular systems, for example, on the maintenance of regular heart rate and rhythm and respiration. So that means if you're using, if you need to anesthetize a patient in the field, for example, where you don't have any support equipment available, then a drug like ketamine might be a safer choice in some respects, in the sense that you're unlikely to risk progressing into stage 4 and threaten the spontaneous respiration of the individual. In terms of just disadvantages, it tends to be fairly slow in terms of induction of anesthesia, so it can take up to several minutes. So that provides more opportunity for stage 2 delirium type responses. Obviously, it's related to PCP in terms of its mechanism, so you can imagine that would be perhaps a little more common, but it is definitely, in terms of at risk of unintentionally overdosing and threatening the life of the patient, it's a safer drug in that respect. In terms of its therapeutic index would be higher. So ketamine's an important tool in terms of an injectable agent that, again, as I said, typically in combination with other agents can provide effective surgical anesthesia and adequate analgesic effects. Okay, so back to the gaseous agents then. If the induction agents that are typically used to give a smooth, rapid progression down to stage 3, if those don't provide enough analgesia on their own, then we've got the gaseous compounds that are typically administered using vaporizers in a controlled setting, of course, where you've got other support equipment. You can rapidly titrate the drug in the individual, meaning you can turn up, turn down the concentration of the gas that's being inhaled, and so you can more fine-tune essentially the depth of anesthesia if the patient's being monitored, then keep them at a level that's sufficient but not hopefully too far or more than what they need to experience to get a good outcome. So the maintenance of anesthesia is the typical use and application of these gaseous agents, and it turns out that drugs like isoflurane and sevoflurane have fewer side effects than some of the older gases that were initially used. Drugs like halothane, for example, these newer compounds have fewer cardiovascular side effects and depression. There's improved pharmacokinetics in terms of how rapidly the patient recovers when you stop administering the gas. And so these agents have some advantages that have been identified over the years from some of the older compounds. Of course, the earliest compound that was used in this manner was something like ether, over 100 years ago, being used for surgical procedures, and that had the important disadvantage of being explosive, so that led to some dangerous problems, obviously, in certain settings with sparks from equipment or people, triggering an explosion in the environment they were in. So these newer agents don't have those liabilities, and the patient outcome is much better due to fewer side effects, essentially. So these gaseous agents, as I was saying, seem to target the GABA A receptor, just like we've talked about with the injectable agents, as in one form or fashion. They all enhance or turn up GABA A receptor activity, but it also turns out that they have a second separate effect on potassium channels in many cells that have been identified by pharmacologists looking at their mechanism of action. So there's a particular class of what are referred to commonly as background potassium channels that help set the membrane potential of cells, including neurons in the brain. And so by enhancing or activating these potassium channels, then you'll recall that potassium was that even though it's a cation, even though it's a positively charged ion, that the membrane potential that potassium would want things to be at is quite hyperpolarized. It's quite negative due to the concentration gradient that's present across the membrane, the plasma membrane of the cell. So because the sodium-potassium pumps are working all the time to bring potassium in and pump sodium out of the cell, then you accumulate a lot of potassium inside the cell, and when you open up new pores and channels for potassium to flux across the membrane, under most conditions, then potassium is going to leave, go down its concentration gradient, and that positive charge leaving the cell then is going to hyperpolarize the cell, make it more negative, pull it further away from threshold for firing and action potential, and so that's going to quiet down that cell that's being affected in that manner. So it turns out that, as I'm saying, then increasing the activity of these channels are going to hyperpolarize neurons. This is going to occur in the absence of anything that's going on with the GABA system. So this potentially then could mediate or explain why these agents tend to have adequate analgesic effects in terms of quieting down neurons with these gaseous agents. And so the IV agents, the IV anesthetics, drugs like propofol that we just overviewed, don't seem to have this activity at these potassium channels, and so that might explain why they don't provide sufficient analgesia or disruption of the perception of painful stimuli. So gaseous anesthetics, maybe somewhat surprisingly, have multiple mechanisms of action that might explain why they not only provide anesthesia in terms of unconscious lack of responsiveness, but also provide adequate analgesia as well. Okay, so these gases, in many cases, even if they're gases that aren't commonly used over the years, as I was saying, this relationship between water and oil solubility, whether the particular gas in question tends to prefer to be in an aqueous environment or a lipid environment, seems to correspond very well with the potency of the agent. So if we're looking at drugs that have a MAC value that's very high, then these are not very potent agents. Drugs that have a low MAC value, you don't need much of it to provide anesthesia, and those tend to be the ones that prefer to be in the oily lipid environment. So the more one of these agents on this line here prefers to be in an oily environment, then the more potent they tend to be in working as an anesthetic. So this was this Overton-Meyer correlation between oil-water partition coefficient and the potency of the agent as a effective anesthetic. So this gives us a clue then as to how these agents, how these drugs are likely working in terms of their mechanism of action, or where they're working in terms of the environment that they're acting at in the cells, in the neurons, and the nervous system. So if we think about that, then what's likely going on is, in both cases, whether we're talking about GABA A receptors or whether we're talking about these background potassium channels, there's a section, a domain of these potassium channels where there's a loop that forms the pore of these channels that spans across the membrane, and so that likely is going to be within the lipid bilayer in that relatively fatty, fat-loving environment of the phospholipid bilayer. And so whether it's a GABA receptor or a potassium channel, then these gaseous agents, these gaseous anesthetics, are likely getting into the phospholipid bilayer and interacting with the protein complex of potassium channels or GABA receptors accordingly in the membrane, in the transmembrane spanning domain of these proteins. So the correlation, the really strong correlation between lipid solubility and potency as an anesthetic then likely directly is related to the ability of these drugs to get into this lipid layer of the phospholipid bilayer and reach their site of action and activate these inhibitory receptors and inhibitory ion channels. So one of the noteworthy kind of exceptions to that correlation graph that we looked at a couple slides ago, in terms of just thinking that you would want the most potent, the lowest MAC value agent all the time, and you wouldn't care or wouldn't want to use any of the agents that were up at the opposite end. A notable exception to that is nitrous oxide. Laughing gas. It still is useful and used quite commonly in gaseous anesthesia protocols in combination with other agents. So the MAC value of this agent is over 100, which means that if you administered 100% nitrous oxide as a gas to an individual, you still wouldn't achieve adequate surgical anesthesia in most individuals. And aside from the fact that if you kept administering it, then you would also kill the individual by suffocating them. So by itself, a nitrous oxide then is not an adequate agent. However, it seems to be very effective as an adjunct in combination with other gaseous agents. And so this synergy allows the concentration of the other agent that's effective to be administered at a lower concentration than you otherwise would need. And this can lead to a decrease essentially in hangover effects, in the persisting toxicities that these agents often induce. People that undergo surgical procedures and general anesthesia often have an extended recovery time in terms of these potent gaseous agents that are administered, as we've just talked about, have a high lipophilicity. They prefer to be in lipid environments, and so especially during procedures when the patient's anesthetized for an extended period of time, then you get a lot of accumulation of these general anesthetics in fatty compartments of the body, and so even when you stop administering them, then you get a redistribution of that agent back out into systemic circulation, and so there can be an extended hangover in terms of recovering from that agent, that exposure. So by combining nitrous oxide into the mix, then you can decrease the amount of the other effective agent that you need to use and minimize these kinds of unintended side effects and persisting consequences of anesthesia exposure. So one of the significant toxicities that I think I brought up before, way back in the signal transduction section of kind of basic overview of general principles and things we talked about first or second week of class, when we were talking about calcium mechanisms, cellular mechanisms of regulating calcium inside of cells, and we mentioned that calcium's critically important signaling molecule as a second messenger, and that cells expend a lot of energy and strategies for keeping the free calcium levels inside of the cytoplasm of a typical cell to be fairly low. So there are calcium pumps in the cytoplasmic membranes, and calcium pumps in organelles, the ER and the SR structures inside, the reticulum structures inside of cells. And so a lot of effort is generated or expended in a cell to maintain appropriate free calcium levels. And so one of the things that can go wrong when individuals are exposed to general anesthetics in some relatively rare cases is this instance of malignant hyperthermia, so a loss of regulation of body temperature. And so high temperatures can be life-threatening in the individual eventually, and this is due to an excessive activation of typically skeletal muscle groups, activity that's going on due to the loss of control and regulation of calcium in the cells of those tissues. And so you remember there's a type of receptors in the endoplasmic reticulum or sarcoplasmic reticulum in the case of muscle cells, the ryanodine receptor. And so the ryanodine receptor normally allows or controls the efflux of calcium out of those internal stores to release calcium into the cytoplasm. And so if you inhibit the movement of that calcium, you'll decrease the excitability of that cell, and that counteracts this hypothermia, this hyperactivity that's going on in these typically muscle tissues. So a drug that we mentioned before, dantrolene, is an antagonist of ryanodine receptors, and then it serves essentially as a effective treatment for this case of malignant hyperthermia then that commonly, it doesn't occur commonly, but when it occurs, it's commonly caused by exposure to general anesthetics. Okay, so I've talked about different types of anesthetic agents today. We've talked previously about analgesics, drugs like opiate class of drugs, for example. All of these agents that we have available can be combined then and used in what's often referred to as a balanced anesthesia approach. So if you combine multiple agents, muscle relaxants, analgesics, and anesthetics, you can get a cocktail, a combination of drugs in your protocol that will accomplish everything that you want to accomplish, and hopefully through some synergistic activity between the different agents, reduce the concentration of any one of those agents that might need to be used through that synergistic activity, and allow you to decrease or minimize side effects and unintended consequences in the individual. So we want to have a rapid induction, minimize the stage 2 hyperexcitability phase that can occur that I mentioned. You want to provide adequate analgesia, relaxation of muscle bed, muscle tissue in the area that's involves the procedure that's being performed. And so this is often going to, as I've just said, involve then a combination of these different agents that would be used in a typical controlled surgical environment, where we're using some agents to induce anesthesia, other agents like anxiolytic drugs, benzodiazepines, for example, maybe midazolam, some agent that would be provided along with an induction agent to try and just sedate the patient, relieve anxiety, provide some euphoria, some feeling of well-being for just the comfort of the individual, along with sufficient analgesia and muscle relaxant, as I mentioned, in order to accomplish the procedure that you want to perform. So the idea that I've mentioned here already is this idea of synergy, and so through a combination of agents being applied, then we can minimize, hopefully, the side effects and unintended consequences, as I was saying. So you'll learn a lot more about the practical aspects of using these agents in the coming parts of your curriculum, where you're actually getting hands-on with some of this stuff. So finally, we're going to finish a little bit early here today. Finally, I'll just put up this quote that essentially the use of these drugs and the induction of general anesthesia, essentially you're taking the patient, you're taking the individual down to, in many cases, a condition or a state that is somewhat life-threatening due to the activity of the drugs that you're applying. And different individuals can respond to varying degrees to certain agents. So there's always, I've heard anesthetists, doctors that work with these agents say that being an anesthesiologist is, 99% of your time is boredom, and then 1% is terror or something, that something's gone wrong. So most of the time things go as expected, and it's very mundane and routine, and that's fine, but then occasionally it doesn't. So that's means that every individual, essentially every patient, is their own experience and experiment. So that's it for anesthesia, anesthetics. That concludes neuropharmacology drugs, and as I said, next week you'll start with antibiotics.
What art is